All right, everyone, welcome. Welcome to SIDP's Antimicrobial Stewardship Certificate Program, Antibiotics 101. I think it has a cool term, and you see it here, Antibiotic Fundamentals. In the next 3 hours or so, over a 5-part video series, you're going to learn everything you need to know about antibiotics. And we're going to start off here with part 1. And it's really before we get into those individual classes, before we start learning all the key things that you all need to know about these different agents, we kind of just want to set the stage with key concepts and terminology, stuff that's going to come up over and over again as we talk about different antimicrobial classes, really just to make sure we're on the same page. So some of this will be review, but review is good. That's how we learn things. That's how we remember things. Thank you for joining us. My name is Jason Pogue. I'm a clinical professor in pharmacy at the University of Michigan College of Pharmacy. The thing I would bring your attention to on this slide, everybody, is do you see my email address there? Please don't hesitate to use it. I am here to help in any way that I can. If there's a point for clarification, if there's anything that I can do to help you better understand this material, please don't hesitate to reach out. You are going to go on a little over a 3-hour journey with me over the next 5 decks here, so please do not hesitate. If I mess up or if I make things unclear, please don't hesitate to reach out to me. So starting off, here are my disclosures. Again, I won't read these all to you. You can see them here. I serve as a consultant for many different pharmaceutical companies, particularly in the gram-negative resistance space. I receive grant support as well. You can see currently from Merck. I've had others in the past, including the government. I don't think they're super relevant to what we're going to talk about, but it's important that you know that and you keep that into consideration. So as we said, this is part 1, right? Part 1 of 5, and it's really the setting the stage. And so what are the objectives of this deck here today? And really they're threefold. By the time we're done, you should understand key concepts and terminology related to antimicrobial pharmacotherapy. Again, those things are going to come up over and over again when we go through the different individual classes, and really to have those key concepts, key fundamentals there. The second thing is something very near and dear to my heart. You should be able to describe antimicrobial PK and PD principles. But in particular, what I really want you to get out of this presentation in particular is I want you to understand those principles, but relate them to how we are going to dose antimicrobials, including some specific strategies that we might use for different antimicrobial classes. The second thing I really want you to take is how these PK/PD principles actually relate to whether or not we consider something to be susceptible. So relating it to antimicrobial susceptibility as well. PK/PD is not the only thing that goes into setting antimicrobial susceptibility breakpoints, but it is a very important component. I'd say it's one of the bigger driving components, particularly in modern day pharmacology. And so understanding that is really important for you to appreciate what you're looking at when something is called S or R. And then finally, what I want to do, and we'll spend the last few minutes here, the last 3 slides on it, is that you should be able to understand how to approach treatment of an infected patient. So how do we start off? How do we modify that down the line? And then how do we make our definitive recommendations? And so those are really the 3 things that we're going to focus on in this deck. And remember, this is to set the stage for what we're going to talk about when we get into all of the nitty-gritty of the individual antimicrobial classes. So before we get into that terminology that we discussed, I think it's important to ground ourselves in what stewardship is. Again, you are in the Stewardship Certificate Program. You're going to get so many people talk to you about stewardship. But I really think that when you're learning antibiotics, when you're thinking about where to use these to take care of patients, it's really always important to ground yourself in the foundation of antimicrobial stewardship. And so the thing that I always like to highlight, and I give this in any talk that I can fit it in, is note that first bullet. When you talk about stewardship, the primary goal, the primary purpose is to optimize clinical outcomes for patients who are infected. And that should always be the front and foremost of your mind. That patient who comes into your institution or that you're dealing with in the outpatient space, you want them to live. You want them to get better as soon as possible. You want them to get out of the hospital as soon as they possibly can. And you want it to happen with the least amount of negative sequelae that come with it. And so your primary focus should be really optimizing the care of patients. Patients who need antibiotics, you're going to get them on optimal antibiotics. And really that's what it is. You can see that sub-bullet there. It's optimizing the appropriate use of antimicrobials. So everyone who you're going to treat with an anti-infective, you should be thinking about optimizing the 4 kind of characteristics of that therapy. The first is the selection. And so what you want for selection is the most narrow spectrum therapy that covers either their suspected or documented pathogens and that gets to the site of infection. So that's step 1, is you want to pick the right agent. The second thing, and I think something that's critically important to us as stewards, is we want to get the right dose. Again, this includes dose optimization schemes, things like maybe prolonged infusions of beta-lactams, which we'll talk about a little bit later here in this presentation. It's also renal dose adjustments for patients who have renal insufficiency to put them at, make sure that they're not at increased risk for toxicity. So the right drug, the right dose. The third is the right route. Again, IV to PO switch is an underrated intervention to make in patients. Again, oral antibiotics are just as effective if they're dosed appropriately as IV antibiotics. And the thing about oral antibiotics is they have 2 big benefits. One is, again, there are risks with IV therapy. Anytime you're manipulating a line, you put the patient at risk for thrombophlebitis. They can get a line infection. So that's one big thing. You want to avoid that if possible. But probably the bigger thing, in my opinion, is that switching patients over to oral facilitates discharge. And we like that. And so again, right drug, right dose, right route, and then perhaps the most important back-end stewardship technique is optimizing the duration. Different infections have different evidence-based durations of therapy. They're often much shorter than you think they are. And so as a steward, it's really important that we're looking for strategies to optimize duration. So again, every patient, right drug, dose, route, and duration. Goal being, we want to optimize that patient's outcomes. But in doing that, we also get to minimize the bad that comes with antimicrobials. And there's a lot that comes into that as well. First and foremost, these are not benign compounds that you are putting into your patients. They come with a significant risk of toxicity. Again, let's use the example of vancomycin, a drug that is used way too frequently in hospitalized patients. Again, there are different factors that might impact this, but it's not out of the realm of reason to say it causes toxicity, acute kidney injury in 5 to 10% of patients. Again, that's a pretty significant risk of acute kidney injury. So if we can avoid that risk, that's a good thing. Again, one of the big reasons that antimicrobial stewardship has taken off over the last 2 decades is to minimize the emergence of resistant pathogens. We know that the number 1 risk factor for drug resistance is antimicrobial use. And so we really want to be optimizing the use to really get the good out of the antibiotics, but minimize the development of resistance. Additionally, and it's a very similar concept to resistance development, we want to decrease the selection of superinfections. Now, these are not infections that wear a cape, but what we mean by superinfections are patients might be colonized with organisms that might normally be kept at bay by their normal microbiota. A couple examples of this would be C. diff. Another one would be yeast like Candida species. And so patients are colonized with those pathogens, but again, they're part of this homeostasis in the patient's body. But if you give broad spectrum antibiotics and kill off a lot of the other bacteria in the body, things that aren't targeted by that can overgrow and cause disease. And like I said, C. diff is an example of that. Fungal infections are examples of that as well. And so again, that's an unintended consequence of usage. And the last one is important. It's not something that we focus on. It's not the primary driver of what we do, but there is a cost effectiveness that goes into this. And unnecessary antimicrobial use is an unnecessary cost to the institution. So again, stewardship predominantly, first and foremost, optimize the good. In doing that, minimize the bad. And that's what you should be thinking. That should be what drives you as a steward. So with that, let's jump into a little bit of terminology. So let's first start off, and again, a lot of you will know this terminology, but it's important to highlight it again, and that's empiric versus definitive therapy. So what is empiric therapy? It's simply therapy before you know what's actually causing that patient's infection. So they come in with a new infection and you have to treat before you get culture and susceptibility information. And empiric therapy is based on the common pathogens associated with an infection and their likely susceptibility profile. An example of this would be community-acquired pneumonia. A patient comes in with community-acquired pneumonia. You have no idea what's actually causing it in that patient. However, you know from a bacterial standpoint, common pathogens include pneumococcus, Haemophilus influenza, Moraxella, and the atypical pathogens. And so you have this empiric regimen that you give up front based off what's likely to be active against those most likely pathogens. Definitive is just once you know what's actually going on. You get cultures and susceptibilities back, and you target therapy toward the pathogen that's causing the infection in your patient. That's where many of the concepts that we'll talk about as we move forward will come into play. So empiric versus definitive. And I'd be remiss if I didn't take this opportunity to highlight to you, as budding antimicrobial stewards, the importance of appropriate empiric therapy, particularly in sick patients, probably most noted in septic patients or those that are hemodynamically unstable. Simply put, just look at the title of this slide. Appropriate empiric therapy saves lives. It's really important in those sick patients that whatever we give up front ends up being active against whatever pathogen is causing that patient's infection. So I just want to show you two publications. They're about a decade apart in publication. There are dozens upon dozens of similar publications, but I like these two because they look a little bit at some of the extremes. With the goal being in this slide is I really just want you to see how important appropriate empiric therapy is in patients that come in and see you in the hospital who are infected. So on the left side of the screen is a famous figure. In fact, as you go into your careers as stewards or continue your career as stewards, I bet you use this figure at some point in a talk that you give. It's almost like a rite of passage to include this. So these are data from the very famous Kumar study in 2006. Yes, it's sad to think about how long ago that is today, but it was in 2006. And these data were actually kind of what set off the Surviving Sepsis campaign in the early 2000s. So just to orient you to the side, these are septic patients. These are hemodynamically unstable patients who are infected. On the x-axis, you are looking at time from hypotension onset to the beginning or administration of appropriate antibiotic therapy. Again, appropriate meaning whatever was given ended up being active against the ultimate pathogen that was identified in the patient. So again, as you go from left to right, you're looking at increased time from within the first hour all the way to greater than a day and a half later. And then the y-axis is just the percent of total patients. And what I really want you to look at in this slide is note the black line. The black bar is the survival fraction. And as you can see, as you go from left, meaning getting them on active therapy fast, to the right, meaning longer and longer delays, you can see the percentage of patients that got started on anti-infectives in those time windows starts to go down. So what you're seeing is the mortality increases the longer it takes. And in this study, which is probably an extreme example, just given the time of when the study was done, but in this study, every hour delay increased the risk of mortality about 7 to 8%. And so if you ever hear that number cited, this is the publication that comes from. But what I want you to note on here is really every hour counts. And that becomes really important to understand and appreciate as an antimicrobial steward, because one of the most important things that we can do is get patients on appropriate empiric therapy faster. But you might be saying to yourself, or someone might say to you, okay, Jason, but that's the sickest of the sick patients. And do I really need to get people on appropriate empiric therapy if they're infected, but maybe they're a little less critically ill? And I'll bring your attention to the study on the right side of the screen, which is one that I think exemplifies the fact that, yeah, you really do. So this is a study that came out of South Carolina looking at patients that had gram-negative bloodstream infections. And so just to orient you to this slide, if you look at the x-axis, note all those fun letters together. Don't worry about what that means. Just know it's a severity of illness marker. The higher that score, the sicker that a patient is. And so patients on the left side are less ill. Patients on the right side are more ill. The y-axis is the length of stay. And what you're looking at in the two different green bars, the dark green bar are patients who got appropriate, meaning active empiric therapy. And the light green bars are those with inappropriate empiric therapy. And while you can see the sicker patients were stayed in the hospital longer, just look at the size of the bars on the right side of the screen. Just what I want to just highlight is that even in those less ill patients, this ones with the scores less than 5, note the impact of appropriate empiric therapy on length of stay. If you got it right up front, your patients got out of the hospital 3 days sooner. So again, this matters across the board. And so one really important stewardship principle is that we want to minimize time to appropriate therapy wherever is possible. And that will require, in certain situations, giving broad spectrum empiric therapy. One really key principle to this that I want you to keep in mind is that you always have to balance that, though, with antibiotic overuse, right? Because if you give too much antibiotic, we already talked about that, right? Number one risk factor for the development of resistance. And so when you as stewards at your institution will develop guidelines, and you'll get some of that in your other presentations from other faculty, when you develop those types of guidelines at your institution, a really important thing to figure out how aggressive to be is risk stratification. Again, patients like those on the left side of the screen, you're going to be really aggressive empirically in their regimen. However, if a patient comes in with altered mental status, otherwise completely stable, being worked up for potential UTI when they may not even have it, your margin for error is significantly higher and you're going to be less aggressive in that scenario. And so again, there's going to be this risk stratification piece that comes to empiric therapy. So that's what you do up front. But then you're going to have therapy modification down the road. And we're going to bring this back when we talk on the last couple slides about how to handle an infected patient. But once you're going to modify therapy, you might hear the term escalation. And what escalation means is that it's an increase in the spectrum of antimicrobial therapy. And usually that's driven either by the lack of response or a suspected or documented resistant infection. So example might be you have a patient who's got hospital-acquired pneumonia, empirically started on cefepime. It's 72 hours later, they're not clinically responding. You think they might have infection with an organism that's not covered by their current regimen, and you escalate their regimen maybe to meropenem, for example. Another example of escalation would be you have a patient who comes in who has urosepsis, they're bacteremic, they're started empirically on ceftriaxone, the blood culture pops positive for an ESBL producing organism, and we'll talk all about ESBLs in the next lecture, but you're going to escalate that patient to a carbapenem to cover for that ESBL. The flip of that, which is a huge stewardship intervention, is de-escalation. Remember, we talked about the importance of getting it right up front. Even though we have to be really broad to do that, rarely do patients actually need that broad spectrum of therapy. And so de-escalation is once you know susceptibility, you're going to bring that back down. So maybe they're on cefepime and tobramycin, but they have a pan-susceptible E. coli, and you're going to de-escalate them down to cefazolin. And then finally, discontinuation is exactly what it sounds like. It is the stopping of all antimicrobial therapy. So moving forward in antimicrobial terminology, this is something that is misinterpreted very much so. And so I'm going to try to, on the next 2 slides, really tell you what you need to know about bactericidal versus bacteriostatic and some of the common pitfalls. And so here is bactericidal versus bacteriostatic in principle. I hope you like this pretty picture because I did make it myself. I won't tell you how long it took me to make it because it's somewhat embarrassing. But basically what you're looking at is on the x-axis, you're looking over time. So if you go to the right, you're going out into the future. On the y-axis, you're looking at concentration of organism. The higher you are there, the more bug that is present. And so again, if you are sitting in a petri dish or if your patient is just being infected with replicating organism, if you look at that blue line, that is what the normal process is going to look like. You're going to get organism that's going to keep replicating, and you get growth of organism. So at that time frame on the right side, you have more bug than you had at the beginning. Pretty straightforward. In principle, what a bacteriostatic effect is an inhibition of growth. And so if you look at that green line, over time, you don't have a decrease in organism, but you do not have a continued growth of an organism. And that's what bacteriostatic means. If you look at the red lines, this is cytality. And what you're seeing there is you're actually seeing kill of organism. So in theory, when you call something bactericidal versus bacteriostatic, this is probably where your mind goes. This is kind of the thought process, the concept of what that means. Unfortunately, however, it's not really that clear cut. And so you often learn drugs. In fact, we'll even talk about them when we get into these various lectures as whether or not they're bactericidal versus bacteriostatic. But what I want you to know is it's not as simple as what you see on that previous slide. The package insert for these drugs, as well as like a book description of stasis or cytality, is actually based on a laboratory definition that is much more complicated than what we just looked at on the last slide. And not that that's necessarily a bad thing, but what's really important for you to appreciate and understand is that those definitions of cytal or static that you'll read in a book or in a review article have not correlated to any clinical outcome. And so they're not really clinically meaningful. And I will tell you that over the past decade, the thought of whether a drug needs to be cytal or static has really gone away, and people don't pay a whole lot of attention to that anymore, at least book definition of static or cytal. Interestingly enough, drugs that are listed as static do actually kill organism over time. A good example of this would be linezolid. Another one would be minocycline. If you look, they're static drugs. But if you actually look at their kind of pharmacodynamic profile, you see that they do kill organism over time. And most importantly, what I want you to understand and appreciate is that last bullet. And the bottom line is that this delineation alone, again, whether a drug class is considered cytal or static in a textbook, really should not influence your clinical decision making. One thing that super complicates this matter is there actually is a PK/PD definition of cytal versus static as well. And it actually is clinically meaningful and influences things like susceptibility breakpoints. So you might see some of that gets a little bit challenging to interpret, and as you can see, there's a bunch of different definitions. But the thing I really want to highlight here is that don't worry too much about that. That'll come into the conversation when we talk about PK/PD next. What I want you to know right now is that kind of book concept of something being static or cytal really should not influence what you're doing for caring for your patients. So with that, let's move into antimicrobial PK/PD. We'll give you a real down and dirty 101 on this. And so when we talk about antimicrobial PK/PD, the first thing is pharmacokinetics. And so you may remember this back from pharmacy school, or if there are non-pharmacists taking this, maybe a nerd like me came into your class to teach you PK and PD. But when you think about pharmacokinetics, the thing that you should always think of is that's what the body does to the drug. It's the process of absorption, distribution, metabolism, and excretion. So the way I think about PK is the PK of a drug determines the amount of drug that is at various sites of my body for a given period of time. Pharmacodynamics, on the flip side of that, is what the drug does to the body, right? So PK gets it to the sites, and the pharmacodynamics becomes the interaction with the body. When it relates to antimicrobial PK/PD, pharmacodynamics means two different things. First off, there is a pharmacodynamic effect that's associated with toxicity, right? So the concentration at cells where they might damage, that's called toxicodynamics. But more importantly, for our purposes today, we're talking about effect, so like therapeutic effect. And so instead of interacting with our cells, the pharmacodynamic effect in the case of antimicrobials is actually what the antibiotic does to the organism at the site of infection. So you have an infection in the lung, PK gets the drug to the lung, the pharmacodynamic effect becomes what the drug does to the organism at that site. And a really important concept as it relates to antimicrobial PK and PD is that antibiotics are either considered time-dependent or concentration-dependent. And what that basically means is that for different classes of antimicrobials, they're optimized or they kill in different ways. If they're time dependent, it's related to getting a constant concentration of a drug at the site of infection for a given period of time. We'll talk more about that in a little bit. If they're concentration dependent, it's actually the more you give, the better. And so you can see those are two different concepts, and they'll have dosing implications a little bit later. A very important term that you're going to hear when you talk about antimicrobial PK/PD is MIC, or minimum inhibitory concentration. And everybody, that's exactly what it sounds like. It's the lowest concentration, that is the minimum concentration, right, of an antibiotic that inhibits growth. So another way of saying that, it's the minimum concentration of an antibiotic that causes stasis in a test tube. And so that's what it is. And there's a way that that can be tested in a lab. But basically what you're getting from an MIC is the smallest amount of drug that causes a static effect in a test tube. And so the question you might have is, what does that mean? And the answer is, in of itself, really nothing. And so just to orient you to this slide now, again, if you think about this as a slide that is just dying for a concentration time profile, on the x-axis, you have over time. On the y-axis, you have concentration of the drug. And if you gave a dose, if you can think back to your old school lectures, you could see, you'd get this concentration time profile. You'd get a peak, you'd have elimination that would occur, and you'd have this nice little curve on here. The MIC is just, remember, it's just that concentration where the minimum inhibition occurs. It's the smallest concentration where you get this static effect. It of itself doesn't mean a lot of anything. However, depending on how an antibiotic works, there's going to be some relationship to that MIC, and we're going to talk about that on the next slide, that optimizes the antimicrobial effect. And again, that's where you're going to get into this time dependency or this concentration dependency. And what's really important for you to understand and appreciate is that the MICs are ultimately used to determine if an organism is susceptible, intermediate, or resistant to that antibiotic. And we're going to talk about that on the upcoming slides. But an important principle that the MIC itself, without exposures related to it, doesn't really tell you a whole lot of anything. And that's why not always the smallest number is the best option. It really comes down to exposures and how the antibiotic works. And so with that being said, how does the antibiotic work, or what different classes work which way? And so you remember on the last slide I said you could imagine a concentration time profile. Now you have one. This is exactly the same as the previous slide, except now I've dosed a drug and I have this concentration time profile that you can see with that pretty slope. And so again, like I said, there's time dependency to some antibiotics, there's concentration dependency to some others. So let's start off by talking about time dependency. And our representative class for time dependency are the beta-lactams. The way that you optimize these drugs is by optimizing the percent of time that the concentration remains above that MIC value. So again, another way to say that is that it's concentration independent, right? It doesn't matter how high you are, you just want to be above that concentration, that MIC value, for as long as you possibly can of a dosing interval. And we'll talk about some strategies to do that a little bit later. The flip of that is your AUC to MIC drugs. And so area under the curve is simply, again, if you look at that beautiful curve that's on your screen, on the left side of your screen, the AUC is just all of that shaded area. And the AUC to MIC ratio is all of that shaded area divided by the MIC. And so if a drug is optimized that way, the way that you're going to optimize a drug is just giving more of it. The more you give, the higher the AUC you're going to get, and that's really how you optimize the outcomes with that. And what you're going to find, everybody, is that most drugs, and you can see it on this slide, most drugs behave this way. It's kind of a hybrid of concentration and time dependency, but we consider that a concentration dependent effect. And again, the way that we're going to optimize that drug is to give more of it if we can safely do that. And then the third PK/PD target that's associated with efficacy are peak to MIC drugs. And the representative class for this is the aminoglycosides, although to be fair, they also very much behave as AUC to MIC drugs. And the way you optimize peak to MIC drugs is by giving them bigger doses less frequently, right? Because the important characteristic of this is you want a high peak. And so you want to give the dose in a way that you're going to get a high peak. And we're going to talk about some strategies to do that soon. And so these are the targets that are associated with efficacy. And so for each of these different classes, there's some sort of target that is associated with good outcomes. For example, it might be a time above the MIC for 50% of the dosing interval. It may be an AUC to MIC, like with vancomycin, of 400 to 600. There's going to be targets that are associated with this. And how that relates to antimicrobial susceptibility is listed on this slide. So the one thing I want to highlight, and we talked about this a little bit already, but I do want to focus on it again. PK/PD is not the only thing that informs antimicrobial susceptibility, but it's a really important part of it, and it's an important concept for you to think of. And so when something is considered susceptible, it means that our PK/PD targets, again, whatever it is, based off what we talked about on the last slide, maybe a time above the MIC of some percentage, it means that they are usually achievable, and you would expect common doses of the antimicrobial that you're giving to lead to clinical success. Now, important caveat here, just because something is susceptible does not mean you're going to have a good outcome. I have patients all the time that are really sick, and I give them an antibiotic that their isolate is susceptible to, but they still succumb to the infection. The key way to think about something as susceptible is that you're giving your patient their best chance with the antibiotic that you're given. So again, susceptible means is that the way that we give the drug, we can hit our PK/PD targets. We've put our patient in the best possible place for a good outcome. The second would be intermediate. And so intermediate, you might also see this referred to some drugs as susceptible dose dependent. The thought process is largely the same. It means those MIC values are elevated for the organism toward the antibiotic in question, the one we're trying to give here potentially in this situation. And you may be able to see clinical success with dose optimization strategies. So there may be a way to improve that PK/PD profile. Maybe it's increasing the dose. Maybe it's administering the drug a different way. But you may be able to see success if you do some dose optimization strategies. And then the final is resistant. And resistant basically means is that with the doses that we give patients, you cannot reliably achieve your PK/PD targets, and you're not going to expect clinical success with the agent that you're giving. Again, much like with susceptible, the thing to remember is that you might still see success. It's just more that the immune system has been the driver of that success in the patient. The antibiotic, you haven't chosen the best one. You haven't put your patient in the best spot for a good clinical outcome. So that's the way I want you to think about it. Susceptible versus resistant. Neither of those will be absolute in determining whether or not you're going to have a good outcome with the antibiotic that you're giving the patient. However, you're either putting your patient in the best spot you can, or you're not really helping them out, and you should try to think about a different option for that patient. So what are some dose optimization strategies based off of those PK/PD targets that we talked about? So again, remember we talked about the beta-lactams. We said that time above the MIC was the big driver. Didn't matter how high you got, just need to have a concentration above that MIC for as much of the dosing interval as possible. And we're going to look at this in the next couple slides because it's a really important concept, because we do a lot of dose optimization for beta-lactams. But two different strategies that you can do to do this is, one, you divide the daily dose more frequently, or two, you give the drug as an extended or prolonged or continuous infusions. And we'll show on the next couple of slides how that optimizes the time above the MIC. But this is a really important stewardship intervention that a lot of sites do to optimize their beta-lactams. When you talk about AUC to MIC, remember, AUC is just going to be driven by the total amount of drug that you give. And so when you're giving that, it really doesn't matter if you divide a drug Q8, Q12, or Q24. It's really just that total daily dose that's going to drive outcome for your patient. And so really you're just looking to optimize the daily dose. It doesn't necessarily matter how you give it, like how we talked about with time-dependent antibiotics. That being said, there are AUC to MIC drugs that while the way you give it won't impact the efficacy, it may impact the toxicity. And two examples of that would be the aminoglycosides and daptomycin. Both of these are really AUC-driven drugs. So again, from an efficacy standpoint, it doesn't necessarily matter how you give them. However, if you divide the daily dose more frequently, you actually increase toxicity. And so there's a toxicodynamic piece that comes into that dosing as well. And then the third, if you have a peak to MIC drug where you're really trying to optimize that peak, you're going to divide that daily dose out to give that high dose less frequently. And again, that's very common what we do with the aminoglycosides, right? We give high dose extended interval dosing because it allows us to optimize that peak to MIC ratio without compromising the total drug exposure that we're giving to our patients. And so with that said, what I just want to show you on the next couple slides is really for time-dependent agents, why we do some of the dosing strategies that we do. Because remember, the beta-lactams are like our favorite drugs. And we'll talk in the next talk about exactly why that is. In fact, it's why we have an entire one of these lectures dedicated to just the beta-lactams. And so dose optimization of those becomes really important because they're first line in our hospitalized patients for a large number of infections. And so let's look and understand and appreciate why we do some of the things that we do. So first off, the benefit of more frequent intervals. Remember I said one dose optimization strategy was to give the same amount of drug that you're going to give that day, just give it more frequently. And so what you're looking at here is, again, I drew this, so I hope you appreciate it. Please don't make fun of me. But basically, this is a drug. Let's just say this is nafcillin, just for funsies. And let's say we decide to give the drug 6 grams every 12 hours. And you got a concentration time profile like this. You can see the dose at time 0. You can see the dose at time 12. And so if you look at this, what you'd see is those little triangles there, those are your times above the MIC. And if you look at kind of where that crosses in our little x-axis, which is the time of the day, you'll see that we're above the MIC for 6 hours with each dose, right? It's a 24-hour dosing window that we're looking at, so that's 12 out of 24 hours. We have a time above the MIC of 50%. Okay, so that's what happens if we give nafcillin in this made-up exposure that I made here, 6 grams twice a day. But for those of you that are astute and are taking care of patients, you probably know that we don't give nafcillin like that. We give nafcillin 2 grams every 4 hours. Why do we do that? Well, the key reason, the really key thing to note when you talk about beta-lactams is they have a really short half-life. And so because of that, no matter really how high you get, every half-life, which is usually 1 to 2 hours, you're going to decrease 50%. So you're going to very quickly drop below that MIC. And so a really key thing that you want to do with giving more frequent intervals is you're trying to minimize the amount of time between doses. So you're minimizing the amount of time that concentration can drop. So as you can see from this slide, the Cmax might be a little bit lower, right? Because you're not giving 6 grams twice a day, you're giving smaller doses. But in actuality, the time above the MIC is greater. The other benefit is because these drugs have short half-lives, right? 1 to 2 hours, you do reach steady state pretty quickly. Again, if you say it's 4 to 5 times a half-life, you're talking probably by dose 2, you're already therapeutic in that situation. And so, as you can see here, this is the benefit of giving a drug more frequently. Lower Cmax, but higher time above the MIC. That makes sense for a time-dependent antibiotic. Again, if I was saying this was a peak to MIC drug, this would be the opposite of what I would want to do, right? And so that becomes really important and why we dose different antibiotics differently. However, what you're going to see at your institutions, maybe now and hopefully in the future, are strategies to prolong the infusion. So why do we do that? And so let's pretend we give dose 1 of a drug and it gets us above the MIC. Are there other things that we can do to try to optimize the exposures of this drug? Well, the first thing that we can do is we can give the dose as a continuous infusion. And isn't that beautiful right there? You can see your time above the MIC is 100%. Really the ideal way to give a beta-lactam. So the question you might be asking is, why don't we give more continuous infusions? And the reason is simple. It's tying up a line, it's tying up resources. It can be challenging to feasibly give drugs as a continuous infusion. And so the concept of prolonged infusion is kind of the happy medium. Instead of giving the drug as a continuous infusion, you give it over 3 or 4 hours. Again, please mind my horrible drawing that you're looking at here. But the key feature, the key thing I want you to know and think about here is, if you're giving a drug, let's say every 6 hours, and you're infusing it over 3 hours, that only leaves 3 hours between doses for that concentration to drop, right? And what that's ultimately going to do is that's going to increase the time above the MIC. And so prolonged or extended infusions of 3 to 4 hours is kind of that happy medium. Again, these things make sense for time-dependent antibiotics, but if we were talking about concentration-dependent antibiotics, they either wouldn't be beneficial, and they'd actually be harmful if they were peak to MIC drugs, or if they were AUC drugs, you're still given the same daily dose, and so it wouldn't have any impact at all. And so that's why understanding time versus concentration dependency is going to influence how we give drugs to patients. And so with that, I want to wrap up our first kind of delve into this by just talking about the general approach to how we manage an infected patient. So step 1, patient comes in. You have a working diagnosis. I think this patient has pneumonia. That infection type will have likely pathogens, and those pathogens have likely susceptibility profiles. And we use this to determine our empiric therapy. In fact, this is actually the type of information we use to develop our institutional guidelines, something you as stewards are going to be very familiar with, if not currently, certainly in the future, because it's a prime function of stewardship is to develop these institutional guidelines. However, again, don't just create a guideline in a vacuum. You're going to take into consideration patient-specific factors. Severity of illness is one of those, right? If you have a critically ill patient, it's important to get it right up front. You might be a little bit more aggressive in your empiric therapy guideline and your empiric therapy recommendation. However, if you have a stable pneumonia patient who you actually don't know if it's pneumonia versus a COPD exacerbation versus heart failure, you're going to be less aggressive in that empiric regimen. So again, you're going to do some risk stratifying there. You're also going to take into consideration patient-specific factors. Did the patient have recent antibiotic exposure? For example, let's say at your institution, your recommended guideline for pneumonia, hospital-acquired pneumonia, is vancomycin. If your patient just got 2 weeks of cefepime might not be the best empiric recommendation. You might give them something differently in that situation. So you're going to consider their antibiotic histories. Additionally, if a patient has a history of an ESBL, you're probably going to want to cover for that empirically. So you're going to think about their microbiological histories. You're going to consider their drug allergies, and you're going to also look at their end organ function. Do you need to dose adjust because they have renal failure? Are they an acute kidney injury? Maybe you don't want to give that nephrotoxic drug. So there's going to be some patient-specific factors that help inform that. But the other important thing is, as you start this empiric therapy, taking all of this stuff into consideration, make sure you get appropriate diagnostic and microbiology workup, because that allows us to make changes down the road. And so now you're at that part where culture and susceptibility data return, and you're going to take that in combination with the patient's status. Are they getting better? Are they getting worse? Are they the same? And you're going to modify antimicrobial regimens accordingly. We're going to escalate in patients with resistant organisms. We're going to de-escalate to more narrow spectrum therapy when appropriate. And we're going to discontinue unnecessary agents. Again, imagine that patient with pneumonia, you start on vancomycin. The organism comes back as a pan-susceptible E. coli. What are you going to do? One, you're going to stop vancomycin because that's only there to cover for MRSA and the patient doesn't have it. Two, you're going to de-escalate that cefepime probably to something like cefazolin. So those are going to be stewardship interventions you make at that point. And then once your patient can, and if you have an oral option, you transition them over to that. Remember, facilitate discharge. And then last but certainly not least, you're going to select the appropriate duration of therapy for their disease state. In my opinion, this is the most important back-end stewardship intervention. I think up front, optimizing empiric therapy, dose optimization are the most important things that we can do to improve patient outcomes. But from minimizing the bad, I think this is the most important one, because longer durations of therapy do not improve outcomes, but they significantly increase harms. They increase the chance for resistance, they increase the chance for adverse events, they increase the chance for C. diff. Different disease states are going to have different evidence-based optimal durations. You can find those in national guidelines, but they're ultimately going to inform your institutional guidelines. And all I'll say is that for those of you that are new to this, they're often shorter than you'd expect. Rarely do you need a duration of therapy greater than 7 days. And there's been a huge push in the last decade and a half to get those. There's been good randomized controlled trial data that have come out supporting that we can give shorter durations of therapy for a lot of disease states. And so with that, you made it through the introduction. I'll see you again shortly as we talk about part 2. We're going to focus on everybody's favorite antimicrobial class, the beta-lactam.